my name is Caleb Aultman. I'm a fourth-year medical student coming from the University of Mississippi Medical Center, and I'm here to talk about a case of multivitamin or multi-system effects of polyvitamin deficiencies in a malnourished patient that we saw. So I'll jump straight into the case presentation. We had a 60-year-old patient who came to us with a relatively benign past medical history, who presented with 2 weeks of worsening generalized weakness and multiple falls. On the morning of presentation, her weakness had progressed to the point where she could no longer rise from bed, which was concerning enough for her to feel like she needed to come in. When she came in, she did report this poor dietary intake over the prior 2 to 3 months, and did say that she had had an associated approximately 30-pound weight loss with that same time frame, and believed this was also contributing to her weakness. She did kind of have an overlapping at the time story of physical abuse by her son, which was very recent, with whom she was living at the time. She denied any kind of these red flag symptoms of chest pain, shortness of breath, fever, chill, abdominal pain, that kind of stuff. But she did report gingival bleeding as well as bruising from her frequent falls. On exam, when she came in, she did have a hematoma to the right temporal region. We did notice gingival bleeding. Her cardiovascular, respiratory, and abdominal exam were all fairly benign. On her skin exam, though, she did have this diffuse pallor. She also had diffuse ecchymosis or bruising in all of her extremities. Petechiae were noted in her bilateral lower extremities, and she did have a large sacral wound. On her neurological exam, it was important to note that her sensation was grossly intact in all extremities. However, there was a diffuse decrease in her muscle bulk as well as a decrease in her muscle strength in her bilateral lower extremities. We did also notice a subtle form of dysmetria. She was areflexic in her ankles. She also had impaired proprioception of the large joints in all of her extremities on presentation. So we got some labs, got a CBC and a peripheral smear, which showed a normocytic, non-proliferative anemia with a reticulocyte count less than 1 at 0.6%. It also showed a thrombocytopenia with platelets at 45,000, and the peripheral smear showed many smudge cells. Importantly, it didn't show any schistocytes. We were looking for those because this kind of presentation of anemia, thrombocytopenia, we have neurologic manifestations here, was concerning for TTP. No schistocytes is obviously a good sign if you're thinking TTP, or we'll kind of take that off the differential. We still did go ahead and get the hemolysis labs, which kind of were confirmatory of that as well, with a slightly elevated LDH, but all the other ones with the indirect bilirubin, the fibrinogen, and haptoglobin were within normal limits. We did get vitamin levels just because she had a history of poor dietary intake, to kind of figure out was there an underlying vitamin deficiency here, and we found a low normal level of B12 and then a significant deficiency of folate, vitamin C, vitamin B6, and vitamin D. So after she was admitted, we kind of wanted to further work up this anemia and weakness. The first thing that we did was we did contact our hematology team because there was a significant concern for an underlying leukemia or something like that with this history of weight loss, the bicytopenia, and this non-proliferative anemia as well. So they did do a flow cytometry, which didn't show any of those pathognomonic elevations we'd be looking for in any of the classic leukemias. We did get imaging of the head as well to look for, kind of a intracerebral process with a stroke was being the most likely thought there. There was no evidence of that. We did also get an EMG to kind of differentiate, do we have a possible autoimmune or inflammatory source of this neuropathy? Thinking maybe like a CIDP with this, what proximal and distal weakness, primarily in the lower extremities, the areflexia. However, that was not reflected on the EMG. It showed a mild to moderate axonal polyneuropathy, whereas CIDP is generally more demyelinating. So that really left us with these symptoms must be explained by the vitamin deficiency. So we pretty much focused our efforts on repleting the vitamins. So we repleted vitamins B1, B6, B9, B12, vitamin C, and D. This, along with a consistent dietary intake and the help of PTOT, resulted in significant improvement of her weakness and the hematologic abnormalities. Enough so that the patient was eventually deemed stable for discharge to a skilled nursing facility. So the importance of this case really is to talk about the overlap that it has with a bunch of other common presentations. Maybe the most common with B12 being that of TTP, especially because B12 can mimic it. It can even cause a kind of a pseudo-thrombotic microangiopathy with the elevated hemolysis labs. So absolutely important to differentiate between those two. It's also important just because with it was an uncommon presentation with this patient having such a significant vitamin deficiency without a strong underlying cause. Especially so for B12 or folate, we would be thinking maybe a history or a strong history of alcoholism, although the patient denied any alcohol intake. With vitamin C, you generally see this in people who are also abusing alcohol, or maybe in the homeless population, or a patient suffering from anorexia, which none of those were the case here. So it took us a while to really narrow in on, okay, this is purely a vitamin deficiency thing here, and that there really was no other cause for her symptoms. But I think it also just highlights the importance of, keeping these on your differential, because I mean, something like scurvy, which is, a secondary thing that this patient had because she had the gingival bleeding, the petechiae, the diffuse bruising. It's not something common that in Western medicine, but something important to keep on your differential when you have kind of these nebulous symptoms of overlapping hematologic and neurologic kind of derangements. So really, that's kind of what I wanted to share, was just the importance of keeping it on your differential, even in patients with a normal BMI, if they're reporting a history of poor dietary intake. And that's my presentation.
Great, Caleb. Thank you so much. I do have one question. So was this patient worked up for anything as far as like malabsorption of these? Because I see like she has a BMI of 27, so she's getting intake. So it was kind of weird to see all these vitamin deficiencies.
Right. And so really, so the BMI is a little bit misleading because the BMI is normal, but the patient was also overweight prior to kind of the onset of these symptoms, or especially the weight loss that had happened in the last couple of months. We did do a workup for kind of like infectious etiology of like a gastroenteritis or something like that, but we didn't do a more in-depth thinking like a endoscopy or a colonoscopy with a biopsy looking for malabsorption. I think, mainly because, I mean, some of her vitamin levels, like the B12, was not even to, the point to get below normal. So it didn't quite clinically fit perfectly the picture of a malabsorption, and it was more in line with just poor intake.